This lecture is very special to the Skyland community as it was created to honor one of our longtime board members, Dorothy Fuqua, by her son and daughter-in-law, Rex and Duval Fuqua, and longtime Skyland Trail friends, Tom and Edwina Johnson. It is now my pleasure to introduce two of these four wonderful people whose vision and generosity make this lecture possible. Rex is a longtime a member of the Board of Directors of Skyland Trail, and he serves as chairman of our Clinical Services Committee. Tom has served as a longtime advisor to me and to Skyland Trail ever since we roped him in to being honorary chair for Benefits of Laughter. They're both great advocates for mental health. They are great supporters of Skyland Trail. They are great friends of mine. Please join me in welcoming Tom Johnson and Rex Fuqua.
Thank you, Beth. Beth kind of took my first paragraph right away. I was going to tell you what the lecture was about, but now you know. We did this 3 years ago to honor my mother on her 90th birthday. We did it to recognize her many, many years of dedication to Skyland Trail and her work to advance the programs here and help build this wonderful facility. She's 92. She is not here, but she will be delighted to know what the response has been, and I know she'll be pleased about the program that you're all about to hear. The reason that I'm so gratified about this full room is that it indicates that Skyland Trail's profile in the community is growing and is tremendous. Both as a treatment facility for adults with mental illness and as a community education center for issues surrounding mental health. Skyland Trail has a national reputation as one of the finest facilities of its kind, and literally over the last 25 years, thousands of people have been helped to lead better lives as a result of their participation in the programs here at Skyland Trail. You know, many of us here have experienced mental illness personally. I can just tell you that my family certainly has experienced mental illness in our family. And the fact that there are treatment facilities like Skyland Trail and people like the folks on this stage who can speak to advances in treatment and also to help tell you about the hope that's involved in the treatments, it's inspiring. And so I'm so thrilled that all of you are here. I know that my mother is thrilled, and I hope that this lecture gives you both inspiration, hope, and education. Thank you. Tom.
Good evening, everybody, and welcome. Edwina and I are delighted to join with Duval and Rex in co-sponsoring this Dorothy Chapman Fuqua Lecture. Incidentally, I battle depression. We love Dottie Fuqua. She's been a friend of ours for more than 50 years. And I must tell you, her commitment to this institution is very, very well known by all of us who've been a part of it. There's a wonderful new building adjoining this property, a part of that is called the Dottie, and I hope that many of you who haven't seen it will see it. We love Skyland Trail, and we love its terrific leader, Beth Finnerty. In my opinion, she is the finest leader of any nonprofit organization anywhere in America. And Beth, we thank you for another wonderful, wonderful program. For more than 50 years in media and in public service, I have been privileged to recruit executives, anchors, reporters, producers, editors, bureau chiefs around the world, network heads, and other important talent. Tonight, with all of you as witnesses to this testimonial, I would like to announce publicly what I have said many times in private. the finest recruit I have ever made in my lifetime is Dr. Sanjay Gupta. Sanjay and I met through the White House Fellowships Program. He was one of 15 in the class of 1997-1998, where he served as an advisor to then First Lady Hillary Clinton. I, at about the same time as he was leaving the White House, wanted CNN to provide splendid coverage, the best coverage of medical and health issues. Sanjay, after the White House, wanted an opportunity where he could make a major difference with his life, both as an active, practicing neurosurgeon, which he is 2 days a week at Emory and at Grady, and as a public servant. At CNN, Sanjay does both. He has been, and he continues to be, an active, practicing neurosurgeon. He's Associate Chief of Neurosurgery at Grady, Assistant Professor of Neurosurgery at Emory, and in my opinion, he's the finest medical journalist in media in the world today. He received his BS degree in biomedical sciences, his MD degree, and his residency in neurological surgery at the University of Michigan. In 2009, he was offered the position as Surgeon General of the United States. He withdrew his name from consideration on the recommendation of one of his mentors who feels that he is making more of a difference in his present roles than any temporary government position. And I will predict there will be other major government offers down the road. Sanjay writes a column for Time magazine. He reports periodically for 60 Minutes on CBS, and he travels the world, particularly to world disasters. He has traveled to war-torn Iraq, where he not only covered that war, but also performed emergency surgery on both United States soldiers and on Iraqi civilians. In Haiti, after the catastrophic 2010 earthquake, Sanjay assisted in emergency surgery on a 12-year-old girl in an operation aboard the USS Carl Vinson. Sanjay is very fortunate, and I would emphasize very, to be married to Rebecca Olson, a family law attorney. She is, as we are here right now, looking after 3 spectacularly smart and beautiful young daughters. Ladies and gentlemen, please welcome Dr. Sanjay Gupta.
Thank you. Thank you very much, Tom. I'm a little choked up, Tom. Thank you very much, Tom, Rex, and of course Beth as well. I'm really delighted to be here. I'm delighted to be here in large part because I think I care so deeply about the same thing that many of you in this room care about. And I'll tell you, since I first heard about moderating this panel, I spent a lot of time learning more about this place. And being a resident of Atlanta, but someone who travels all over the world, I just say I'm so delighted that a place like this exists at all, let alone in our backyard. I think the comfort that it gives so many people in this community is just something that's really hard to put a value on. So thank you for all the work that you do. I will also say, especially after Tom's introduction, I'm a little nervous to actually be talking to real live people. I don't get to do that very often. TV's actually quite different. You sit in a dark studio and you talk to a camera. There's a couple guys in tool belts who are sort of walking around and they're telling you when you're live and when you're not by waving at the camera. Sometimes they forget to tell you this. So one time I was actually getting ready to do a segment, and it was somebody's birthday up in the control room, and they decided to bring me a piece of cake down to the set. I was eating that cake right as we came out of commercial break, literally a piece of cake in my mouth, and I kid you not, the segment was on childhood obesity. So, yeah. You wear this little earpiece in your ear. You've probably seen this if you watch television, and it's one of those. It was the hardest thing to get used to, was wearing an earpiece because people are trying to talk to you while you're trying to talk as well. And in my case, at least when I started, it was usually something like, "You look too serious, you should smile more," or something like that. But I want to say, because of Tom, I decided to add this new chapter to my life. And it was really the main reason I decided to come to CNN and do this sort of work. Not just because he led the organization of CNN to such great heights and took risks that other people wouldn't take and redefined television news in the process. He did all of those things, but it was more because of the kind of guy Tom Johnson is. And people who know him know what I'm talking about. He's the guy that would say hello to everyone that passed him in the hallway, would never for 1 second not help somebody who needed help. And he set the tone, a tone that I really, really appreciated, especially at a very formative time in my life. Set a tone about the kind of person that I would like to be myself. And it was this idea that you can work hard, you can be the very best in the world at what you do, and you can still be a tremendously decent human being. So I've learned a lot of lessons from you, Tom, both spoken and observed, and I thank you for that, Tom. Thank you very much. I had a lot of enthusiasm coming to CNN. It was this big change in my life. I was excited to work with Tom Johnson, and just a few months after I started, he announces his retirement. Hard not to take that personally, Tom. Wasn't me, I don't think. But what many of us in this room now know is that there was another lesson really even there. Because Tom could have stayed longer. He could have led CNN to even greater heights. But he decided to do something very few people do, especially when they're unquestionably at the top of their game. He decided to put his family first. He decided to put himself first, and also his mental health. And that was a lesson I will never forget as well. And I admired you even more for that, and it's a big part of the reason that I am here tonight, because I think this is so important. It is safe to say that everyone in this room, everyone, period, interacts daily with someone who has mental illness. Now, for some of you in the room, that may astonish you. That may surprise you. And it's in large part because you don't always know who they are that you're interacting with. You see, it takes courage, I find, as we do reporting on this, it takes courage to simply be forthright about this illness. It takes courage because they know the likely response may be that they are somehow weak, they are somehow defected, that they should just try harder. It's courageous because even the medical system as a whole may not offer them the same level of service because of their diagnosis. It's more courageous even because of the news even over the last couple of days and the barrage of shootings over the past couple of years. It's taken a toll, I think, on our national psyche. And I think it leaves us stunned and it leaves us vulnerable, but it also leaves us more likely to blame, to simply cast blame. I see this a lot in the media, and it's something that we're trying to address. That blame immediately starts to fill the void in knowledge surrounding mental illness, and it leaves us with more entrenched stigma. Something Beth talked about, something we're going to talk about tonight. We do know that some violent offenders, maybe even the offender in DC, have evidence of untreated or partially treated mental illness. But it's really important to say, and I say this a lot when I'm out there reporting on these, not all perpetrators of mass violence suffer from mental illness. It's really important to say that. And most people with a mental illness are not violent. They're more likely to be victims of violence rather than perpetrators. And yet the stigma still persists. When Beth and Tom first approached me about this, I had just returned from Sandy Hook. And it was one of the saddest stories I'd ever covered. I think when you have children of your own, everything changes. I remember seeing those young children's drawings and seeing their shoes and seeing these little things that kids will put into their book bags every now and then, things that they hold so valuable, and they tuck them away for a future occasion. And that was just so sad. It was unthinkable and unspeakable. Yet I also realized there was work to be done, and it was a teachable moment to make sure that the discussion didn't lead to a worsening of the stigma around mental illness. It was a teachable moment to talk about facts, but also to dispel myths. It was a teachable moment to know that the inevitable discussion around guns would occur, but to also remind people that mental health services are pretty fragmented, pretty underfunded in this country, and that also should not be left out of the discussion. That discussion needs to happen. It's such an important part of our reporting, but it is challenging, I will tell you as a reporter, and this is one of the areas we're going to dive into tonight. Mental illness seems to create these situations where people are essentially written off in many ways. It is all that people hear sometimes, and is all they need to hear, it seems. But north and south, rich and poor, old and young, people who can work, people who can't work, we know this can strike anybody, and it undermines the welfare of our nation, something else we're going to discuss. Now, what I sort of think about a lot is this idea that once you hear a lot of this, and many of you in this room may already know this, you would think that we would have done more surrounding mental illness already. It would be something that we're all talking about, that it would be at the top of a political agenda, for example, that we might be falling over each other trying to come up with solutions. But it doesn't happen that way. It doesn't happen as it would with a somatic or a physical illness. It doesn't happen at a societal level. It doesn't happen at a personal level. Someone's in the hospital with heart disease or even a broken bone, the get well cards come flooding in. But if someone's in the hospital with mental illness, they may not get even one. It is a subject that we still instinctively avoid. And again, part of the reason I'm here tonight is to hopefully start to try and change that. It's a shame that people pretend that something else is wrong when they are struggling with depression. That is a shame. These people are our neighbors, they're our spouses, they're even our children. And I have to say that I was really struck by talking to some of the parents in Newtown and talking to lots of experts around the country about parents in particular who may notice or start to notice some warning signs in their own children and may be more likely to ignore them. Not because they don't love their children. Of course they love their children. But because this systemized stigma has led to this perverse risk-reward system where they recognize there's a real risk of speaking openly in order to get the reward of treatment. That can't be the way that it is. We are intimidated by this culture that surrounds mental illness, and that needs to change. We know it's possible. We know this is possible. We know that this is a solvable, fixable issue. We know that with regard to other diseases that have had so much taboo around them, whether they be cancer, AIDS, sexually transmitted diseases, we've been able to slowly change culture. And that's part of what we're trying to do here as well. If you watch my segments, you know that I'm not the kind of guy who likes to spend a lot of time rehashing problems and redefining the statistics. If we believe these issues are solvable, then we should settle for nothing less. I returned from Syria just last week, and I can tell you that there are complicated issues over there. There are mixed allegiances that have been so constantly stirred and amalgamated since the days of the Ottoman Empire, it becomes really difficult to figure out what's happening there in the Middle East. The issue of mental health should not be like that. It is a shame that people suffer because they are too embarrassed to seek help. And so we will continue to do our part in the media, taking advantage of the teaching moments and hopefully changing the way that we can all openly discuss mental illness. It's a real goal of mine, and hopefully it will be a goal of yours after tonight as well. Now, speaking of teaching moments, we're going to have plenty of them tonight. I want to introduce you to our wonderful panel. We're going to hear from all of them. We're going to get a chance to answer some of your questions as well. Dr. Ray Kotwicki is here. He is the Chief Medical Officer for Skyland Trail. He's also an Associate Professor of Psychiatry, and he's going to be talking about something I find really fascinating, the mind-body connection. Dr. Alex Crosby is here as well, a medical epidemiologist at the CDC. Now, he's led investigative teams addressing adolescent suicide clusters, and he's going to be talking about his work in terms of connecting young adults to services that they need. And finally, Linea and Cinda Johnson. They wrote this book. It's called Perfect Chaos. I've watched them on YouTube. We are delighted to have them, and their topic tonight is living with bipolar disorder. So please welcome our panel.
Well, this is the presentation analogy of having to eat your peas after dessert. Following Dr. Gupta is a tough task, and I hope that I will do justice, because what I hope we can talk about is a really important connection that I feel is a major part of the equation of destigmatizing mental illness, which is this: the power of words in understanding that mental illnesses are physiologically based just like any other medical problem. Here's some headlines from newspapers. Schizophrenic opens fire at movie theater. Soldier with PTSD shoots civilians at Navy Yard. have you ever heard in the newspaper, diabetic crashes into tree? I think that this sends mixed messages about the role of mental illnesses in news and the way that we communicate about people who have mental and physical problems. I think that words are extremely important. And when we talk about, over the next 45 minutes or an hour, the use of words, I think this is a major piece of undoing the stigma associated with untreated mental illness. For example, Dr. Crosby is going to talk about completed suicides. We don't want to use terms like successful suicides, because a completed suicide is my failure and your failure rather than a successful event. Researchers on medication adherence have demonstrated that if you call medicines medications instead of drugs, patients might take them easier because we tell people, say no to drugs, but please take your medications. And that is maybe a complicated thing for people who have brain disorders to be able to sort through and to be able to understand the nuances and the differences of the words that we choose. So tonight, I am reclaiming a word that has a lot of emotion and passion behind it from people for very valid reasons, and the word is patient. I respect that historically people with mental illnesses were mistreated, were treated very paternalistically, and didn't feel like they were in control and autonomous in the course of their recovery from their mental illness. However, I think that this word and this label, perhaps, is a really important way to understand the interconnections between somebody's mind and body. And to call a certain group of people who have an illness clients or consumers or something else, and then another group of people who have an illness, a patient, sets a disparity that I think perpetuates the stigma of mental illness. So let's talk a little bit about the reasons and data that we know from the medical literature to demonstrate that mental illnesses are medical problems. And I'm going to start, I'm falling into my medical student education role. There are no quizzes or tests after my going on and on, but I want to provide data that I think is compelling to try to help understand that mental illnesses are medical problems. And let's start with the serotonin story. So serotonin, we all know, is a neurotransmitter that is involved in depression. And you hear a lot of people talking about medications that modify serotonin. Classically, we even call them selective serotonin reuptake inhibitors. But for those of you who made the mistake of taking Latin, like I did, now's your time to shine, because if you dissect the word serotonin, you might be able to glean from the origin of this word that what we're actually talking about is a chemical in somebody's bloodstream that regulates the vascular tone. So how big or how small blood vessels are, like arteries or veins. Serotonin actually wasn't discovered by a neuropsychiatrist. It was discovered by a cardiologist who was starting to understand that this hormone, this neurotransmitter as we've come to understand it, is important in regulating the activity of somebody's heart and their blood vessels. So taking this a step further, roughly 20% of patients who are hospitalized for heart attacks develop, after their heart attack treatment, major depression. And if you develop depression after having some kind of cardiac event or phenomenon, your risk of dying from future cardiac problems goes up by 300%. So the standard of care now is, even in people whom have never previously had depression, if they have a certain constellation of problems related to their heart function and their vasculature, one preventively starts a selective serotonin reuptake inhibitor to make sure that people don't develop depression and that we can use this medication to help in the recovery from heart problems. This is an inextricable link, in my point of view, between medical health, physical health, and mental health. Let's talk about people who have depression, and on average, how they might differ from other people who are matched in every other way in the general population, with the exception of not having depression. We know, for example, that people with depression as a population, not maybe individually, but on whole, have higher core body temperatures than people who don't have depression. We know that people with depression on whole have lower heart rate variability. So if you ask somebody who has depression to get on a treadmill and start exercising, the rate at which somebody's heart will pick up and slow down based on the speed of the treadmill is less variable than in people matched in every other way who do not have depression. We also know that people with depression have the cardinal signs of inflammation. We know that people, for example, with depression have increased rates and amounts of inflammatory mediators in their system, particularly interleukin-6 and tissue necrosis factor alpha. And we also know that people have increased cellular molecules that indicate current active inflammation if somebody is currently depressed. There's ongoing research here at Emory, at Skyland Trail, across the world, in fact, to try to understand if treating inflammation might be a different and adjunctive way to treat depression. There have been studies out of Denmark and other places that have shown high-dose non-steroidal anti-inflammatory medications like aspirin, that these things might have a role in trying to clinically help somebody who's depressed who isn't responding to traditional antidepressant treatment. This is an inextricable link between the way somebody's body works and the way that somebody's mind works. Let's move on and talk about what I think is a very misunderstood mental illness, which is schizophrenia. We know that patients with schizophrenia have many, many more medical comorbidities. We know that people with schizophrenia have increased rates of heart disease, lung disease, and diabetes even before they start taking medications like atypical antipsychotics that exacerbate those problems and might make it even more difficult to manage the physical symptoms. It's also my problem, and the problem of physicians in the audience here who stigmatize people with mental illnesses when they present with very profound and clear physical symptoms and signs. For example, we know that people with the cardinal signs of a heart attack might show up in the emergency room with crushing chest pain that radiates to their shoulder and their arms, and sweating and feeling short of breath. And if on the cover of their chart it says schizophrenia, the ER doc might call me rather than calling somebody who knows how to manage an acute heart attack. And that's a huge mistake. So I think providers might believe that people with mental illnesses have only symptoms related to their mental illnesses, or that they might even be too sick because they're hearing voices that other people can't hear, or seeing things that other people can't see, to talk about things like smoking cessation, getting mammograms, getting colonoscopies, and all the other things that we wish for every human being to be able to have from a preventive medical perspective. In sum, the outcome of this inattention and these increased risks is increased morbidity and an overall decreased life expectancy of people with serious persistent mental illnesses like schizophrenia by as many as 20 to 30 years, depending upon studies that you read. So this has been a very pessimistic talk so far, and I apologize for that. I'm not trying to drum up business for Skyland Trail. Although if you need help, please reach out so that we can try to help with you. But I want to end on positive things, things that we can do from a very practical perspective to decrease the stigma associated with mental illness and to further help educate one another that mental illnesses are medical illnesses. And here are some suggestions. Number one, we need to be very specific in our word choices. I think normalizing psychiatric illnesses as medical problems is a good start. I think disavowing the implicit reinforcement of the stigma that is sometimes perpetuated in the media is a second important step. And I want to thank Dr. Gupta for his trailblazing work in this area and the way in which he talks sophisticatedly about mental illness and the role of mental illness in medical health is phenomenal. And I think we have to educate new doctors and the public and everybody in this room about the data that I think are quite compelling that suggest brain disorders like depression, bipolar illness, and schizophrenia have physical origins. In fact, we know they're genetically based and that there's an inextricable link between the signs and the symptoms of those mental illnesses and medical problems. Finally, I think integrated care is essential. We have to include medical care with psychiatric care. Skyland Trail was one of the first facilities in the nation that has a co-located medical clinic here for all patients enrolled in every level of our services. And we're currently working on some research programs that look at it the other way, which is if we can help people physically, will that result in improved signs and symptoms of their mental illnesses? This turns out to be a really wise economic decision. For example, 1% of the world's population has schizophrenia, but that 1% of patients consume about 85% of the resources used in mental health care. So this makes moral sense, it makes economic sense, it makes social sense, and I would argue that we have an obligation to do that. So in conclusion, I really don't care that much about the word patient. What I do care about is that we treat people with mental illnesses analogously to the way that we treat patients with other medical problems. My hope is that research and clinical data that show the undeniable link between one's mind and one's body will continue to reduce the stigma associated with mental illnesses. So I reclaim this word proudly, and I agree to respect those of you who want to use different words. But the way in which we continue the dialogue about this is what I most care about. Thank you.
So I'm gonna ask a couple of questions, and then we're gonna hear from the rest of our panelists, and then again, we're gonna hopefully hear from you as well. Let me just share something with you. Last night, Ronnie Selig, who runs our medical unit, is here as well. And last night, we had a lot of calls about what had happened in DC yesterday. And at the end of these calls, we sort of decided that we weren't going to go out with our coverage or be speculative or hazard any guesses as to who this man was or what his situation was medically or mentally. When you first heard this, and this is a little bit of a selfish question because I'm curious from your perspective, telling me as a reporter, what were you thinking, and how do you sort of start to piece things together? What advice would you give in terms of people getting the right message in a situation like this?
My reaction was, oh no, here we go again, because the tendency is for people who are well-intentioned, I think, to start playing Monday morning quarterback and saying, oh, this person clearly had an autism spectrum disorder, or in this case yesterday in DC, this person clearly had post-traumatic stress disorder and needed treatment that he wasn't able to obtain. I think that equating having a mental illness with being somebody who's malicious or vindictive or out of control for other reasons is a very dangerous thing to do. And until I personally can do an assessment on somebody like the shooter yesterday, I think it's impossible to look from an outside perspective or a 20,000-foot vantage point and say this is somebody who had mental health problems rather than other things that we don't know about his personal life. So I think it's dangerous, and we know that people with mental illnesses, as you pointed out, are much more likely to be victims, but they're also much more likely to be aggressive toward themselves. And if you look at the number of people who die from suicide, who have depression and bipolar illness and schizophrenia, it's quite clear. And Dr. Satcher, when he was Surgeon General, did a landmark study about the epidemiology. People with mental illnesses are much more dangerous to themselves than they are to anybody else in the public.
I want to talk a little bit about the future later on, but you alluded to this in your talk, the stigma that exists even within the medical system. The ER doc who will call you instead of calling a cardiologist about a heart attack. How difficult does that make your job? I mean, when that example aside, we're trying to convince large communities of people to erase the stigma that has been so entrenched, but even within the medical establishment, it still exists.
Ironically, I think it is even worse in the medical establishment. Let me give you an example of a conversation I had yesterday. A third-year medical student at Emory came to talk with me about what specialty he wanted to go into. And he said, you know, I really liked my psychiatry clerkship, but I want to be a real doctor. And my response to him was, well, that's exactly what you could do. You could be a real doctor and manage people's cardiometabolic syndrome and their diabetes and everything else while you have an opportunity to actively listen to their narrative about who they are as a human being. We know that over half of all of the practicing psychiatrists today are aged 55 or older. So in the next 10 years, theoretically, half of the workforce could potentially retire and not be able to practice. And even still, about 2, and it depends on what year it is, but roughly 3 on average % of all American medical students choose to go into psychiatry. And I think it's because, one, there's a stigma within the medical community itself about psychiatry not being an actual medical profession. And two, I think that the models in which people learn about mental health treatment often are at programs where recovery isn't the goal. It's about containment. It's about making sure we keep people unseen. It's about making sure that we make it impossible for somebody with a mental illness to do anything bad. And what we do at Skyland Trail and what I think good recovery programs do is flip that model on its head to say recovery is possible. Just like if you had a broken bone, you can recover from that. And I believe that you can do the same thing from mental illnesses. And that will attract people to the profession.
Terrific. We'll be back with you in just a little bit, but Dr. Crosby.
Well, good evening to all of you, and I wanted to thank the Skyland Trail organization for the invitation to come and to talk with you and to be here for the Dorothy Fuqua lecture. And I'm going to talk a little bit about how we try to approach the whole issue of suicidal behavior from a public health perspective and try to show you a little bit about that interaction and how you try to access services for youth. One of the ways that we try to address the particular problem, and it really doesn't make any difference whether it's hepatitis, whether it's HIV, whether it's high blood pressure, whether it's cardiovascular disease, is what we call the public health approach. And you can see it depicted there in the yellow, trying to assess what the problem is, figure out what the who, what, when, where is of a particular issue, then moving on and describing what are the risk factors. That's the why question. And determining based on what that why is, then moving on down and describing what are the programs and the policies that you can use to try to prevent it, and then lastly, implementation and dissemination. How do you now get the word out? If you figured out what works and also what doesn't work, how do you now get the information out to the public? How do you get them out to community-based organizations? How do you get it out to organizations that might be dealing with that population so that they can try to be doing something about it? As I mentioned, in terms of talking about the issue of suicide, and as Ray kind of alluded to, suicide is a leading cause of death in the United States, the 10th leading cause of death for 2010. That's the latest data that we've got for the whole United States. But you can see here with this slide, in terms of leading causes of death, suicide disproportionately affects young people. And you can see there for those who are adolescents, 15 to 19, those who are 20 to 29, 30 to 39, suicide is the second or the third leading cause of death in those populations. And so it's an important issue regarding the health of those populations that affects not only those that die as a result of suicide, but their families, their communities, their neighborhoods, and their whole cities, their whole towns, their whole communities. This is just looking at what we've seen in regards to the rates and the numbers of suicides in the United States. One of the things that has changed recently, and that's especially since about the mid-2000s, is that while previously the highest suicide rates had been among those over 65, one of the things we've seen recently, and especially since the Great Recession, is that suicide rates have gone up among the middle-aged in the United States. And you can see here that the peak of those two graphs, the yellow as well as the blue, are among those in their 30s, 40s, and 50s. So that's where we're seeing the most suicides recently in the United States. In addition, you can see that there's disproportionate effect of deaths due to suicide among males versus females. Rates among males about 4 times higher than females in the United States. And you can see especially among elderly males. That's where some of the highest rates are, but you can also look and you can see among females that their highest rates are in that middle-aged population. So again, trying to look at how we describe that problem of suicide and which population, which age group, which sex you might focus on in regards to trying to prevent the problem. Here you can see a number of different lines. I think I'm going to take the opposite approach of Ray, and he said there'll be no quiz. I'm going to ask you about this chart as soon as I get done, so that you can try to recreate all of those lines there. But this is just to show that there are some different distinctions, some different patterns when you look at the different racial and ethnic groups in the United States. You can see there, especially among American Indians and Alaskan Natives, very high suicide rates among adolescents and young adults. When you look among white non-Hispanics, the highest rates are among those in middle-aged populations. So if you're thinking again about how we're going to focus our prevention activity, depending upon which population you might be talking about, you might be looking at a different age group that might be the most effective or the most high risk or the most at-risk population for which you do your program. Here you can see a map of the United States and the rates of suicide across the United States. One of the things you'll notice is the highest rates occur among those Rocky Mountain states. That's been known for many, many decades that that's where the highest rates are. And you can kind of trace a line from the Canada border straight down to the Mexican border and see that here is where the highest rates are. So even across the United States, rates are not evenly distributed. Lowest rates tend to be in the Northeast, highest rates out west among the Rocky Mountains. What do we know about what's going on in those populations? What are the risk factors that we might see there? One of the things to also know about suicidal behavior is that deaths are really just the tip of the pyramid, just the tip of the iceberg. That when you start talking about those who have made a suicide attempt, you can see here with this pyramid, deaths over 38,000 in the United States in 2010, but emergency department visits over 155,000. Those who have come, hospitalizations over 155,000, emergency department visits almost 500,000. So if you are looking again at what is the distribution, what is the burden of the problem, deaths are an important thing to try to prevent, but don't forget about those who attempt suicide and who may have engaged in suicidal behavior, to think about what are the prevention activities that you might deal with that group also. Here is just to show you a little bit of a difference. This is an emergency department system that we have. And when I showed you that males die of suicide, their rate's about 4 times higher than females. On this slide, when you look at the orange, these are suicide attempts that are coming to an emergency department. And you can see with almost every age group, with every bar, females higher than males. So again, kind of flipping that and looking at what's the difference here. If we're talking about deaths, we might be talking about males being the highest risk group. But when we're talking about suicide attempts, we might be talking about females, and especially adolescent and young adult females. Here are a number of risk factors. Suicide really is a multifactorial problem for which we know that mental illness is a big risk factor, but we also know that the majority of people with clinical depression don't die as a result of suicide. So we know that there must be other factors that play a role. And here you can see just one way that we've talked about some of the overlapping factors that may play a role. Here I've got some of the risk factors as well as some of the protective factors that occur at the individual level. There's difference in regards to age, in regards to sex, in regards to things like substance abuse and other kinds of mental illnesses being risk factors there. At the peer and family level, we know a family history of interpersonal violence. For example, we know that children that grow up in households in which the way mom and dad settle something is dad knocks mom down. Children who are exposed to that family violence have a higher risk of suicidal behavior, and especially children who are victims of child abuse and neglect have a higher risk. There are also risk factors at the community level. You can see there, actually, I've got some of the protective factors there. Spirituality has been shown to be a protective factor against suicidal behavior. And then you see down at the bottom, social support versus social isolation. Those who don't have that network of friends and family tend to be at risk. Those who have that stronger network are more protected. And then also at the societal level, what are some of the risk factors there? And we know that things like inappropriate access to lethal means, we know things like geography, just like I showed you with the states. Those are some of the factors that we've seen there. Two of the big ideas in regards to suicide prevention programs, especially when you're talking about youth programs, have to do with primarily getting those youth access, referral, recognition, and referral. How do we recognize those that are at risk and then get them to the appropriate services? That's one main strategy of trying to deal with suicidal behavior. Another main strategy is recognize those risk factors and try to decrease them, and also decrease those and increase the protective factors. So those are two of the main strategies that we've got there. Here is another way of looking at it, and this has got a lot of stuff on it, so I'm not going to ask you about all of these kind of things, but there are ways in which you can be more strategic about some of those different risk and protective factor programs and some of the things that you can try to do. Universal programs, programs in which you might target, for example, a whole school. Are there things that we can teach children in terms of problem solving, in terms of coping skills that can actually decrease suicidal behavior later on? There are terms of types of selective programs in which you're focusing on an at-risk group that you're trying to prevent them from going on and becoming at greater risk for suicide, and then indicated programs. Those have already manifested a risk factor. How do you try to deal with them? Here we've got some of the different things in terms of a national strategy. Those of you who may not be aware, there's a National Action Alliance for Suicide Prevention in which the Surgeon General has convened a number of public and private organizations to try to address and try to develop a national strategy for suicide prevention. These are some of the components of that particular system, but it tries to set a road mark for where we can go in the United States, very similar to what other countries have done, to try to decrease suicide by developing a comprehensive type of approach of decreasing suicidal behavior. Here is, in regards to a conclusion, that we believe that suicide really is a societal problem. It's not anything that just one group, one organization, one discipline can try to address, but there are ways in which all different kinds of disciplines, whether you're talking about the schools or the medical community or public health or law enforcement or social services, all of them can have a role to play in regards to suicidal behavior. We know also that research has shown that while it's a multifactorial problem, that oftentimes you can intervene in one place and make a difference. And I showed you all of those overlapping Venn diagrams. But it doesn't have to be that you address every single one of those risk factors, but oftentimes you can just address one that actually lowers someone's risk for suicidal behavior. There's a broad responsibility for addressing the problem. It's not just any one group, not just any one individual, but a number of us have a role to play in regards to suicidal behavior. I think that's it. Thank you very much for your attention. And as I tried to talk about what is the public health approach to trying to address suicidal behavior.
Dr. Crosby, I had just a couple of questions, and we'll ask you some more later on. When I hear these types of statistics, I think I immediately start to ask why some of the trends are the way that they are. And I don't know how much of that is part of your work. You identify the data, but as part of reaching out to these high-risk groups, do you look and say, why is it that people in their 30s, 40s, and 50s have this increasing rate, for example, of completed suicides? We have done that, and while our surveillance data, which is pretty much just collecting some of the very nuts and bolts of what's going on in regards to suicide, don't answer the why question, they just kind of show you the patterns. We have done more research on the risk and protective factors. For example, we did a study, while some of has been known for a while in regards to economic issues can have an impact on suicidal behavior. That's been known because many studies have looked at the Great Depression back in the 20s and have shown that was the highest suicide rates we ever had in the United States, historically, the highest rates there. But none had looked at some of the other economic booms and busts that had occurred in the United States and seeing, well, did that pattern play out? We actually did a study at CDC and found that, yeah, you could actually look at some of the economic booms, the economic depressions in the United States and find there was actually a pattern in regards to suicide going up when there was an economic downturn, suicides going down when the economy went up, and we particularly looked at certain age groups and found, as you might imagine, sometimes you do research and you say, well, duh, we should have known that actually it's working age adults where it's the main influence of those. And again, we said that suicide is not just one thing.
So it isn't just the economy, it isn't just unemployment, but oftentimes if you have a number of different factors, if social support is affected by a loss of a job and a family dysfunction occurs as a loss of a job, now you've got several factors. Is substance abuse now, part of the picture there, that now you've got 3 or 4 factors that may put an individual at risk for suicidal behavior.
And just really quickly, looking at that one slide, you had the 4 concentric circles, looking at all the various things that could be going on in one's life. How much do you think about the nature versus nurture discussion when it comes to suicide?
We definitely have considered that, and I think as Ray mentioned too, that we know that there are some genetic components to some of the mental illness, for instance, clinical depression, for instance, schizophrenia, for instance, bipolar disorder, that we know that there's a genetic component. I think we then also look at not only what is the physiology or the mental illness, but we're also looking at what is some of the environment, the social environment that the person is in. And just like I mentioned, there have been several studies that have longitudinally looked at some of those with mental illness, and with clinical depression, they've shown that actually less than 10% of people with clinical depression die as a result of suicide. So there must be something else besides the clinical depression that puts somebody at risk. So there are other things besides just that genetic component that the environment can play a role to.
All right, thank you. We'll have more with you as well later on. Mom, daughter, which is going to go first? Mom, okay.
Save the best to last.
There you go.
Yes. First of all, thank you so much for spending your evening with us, and thank you for having us here from Seattle, Washington. We came out and the weather is fantastic, and I'll give you a little hint, it doesn't rain all the time in Seattle. So I got my PhD in special education and particularly an emphasis on mental health in adolescents, and I was teaching a class to graduate students who were pursuing their degrees in counseling and psychology, and I was teaching them about how to do assessment of students who were exhibiting problem behaviors in classrooms and how to develop intervention plans to support these students. And my research is really looking at that area. But I was breaking the rule in the classroom of my graduate students because I had my cell phone on the table in front of me because my daughter was on suicide watch in the hospital down the street, our trauma center in Seattle, which is Harborview, University of Washington's trauma center. And here I was, the know-it-all about mental illness, supposedly, with young adults, and I couldn't keep my daughter out of a lockdown unit with 24/7 eyes on her because she was suicidal. But what I decided to do at that point was, thank you, colleagues, for talking about this, because I thought, you know what, I'm not ashamed of this girl. I would not be ashamed if she were there with diabetes. I would not be ashamed if she were there with leukemia. And so when someone said to me, why is your daughter in the hospital? I said, she has a severe depression. We don't know exactly what it is yet. That was my entry into the world of a parent with a young adult with a mental illness. And I'll tell you, it's a whole lot harder than a professional telling people what to do, because all of a sudden I was the one trying to find the psychiatrist that would take our insurance, would see her within 2 days because we brought her back from Chicago. She was very, very ill. I was the one in those phone trees ready to just scream because I was passed on to one more person to tell the story. And my husband works at the University of Washington Medical Center. He's a rehab counselor. We're at the psych unit, actually not the psych unit, I'm sorry, the psych ER at Harborview. We are downstairs in this place. He's got his medical badge on. I've got, my Seattle University professor badge on. And we're in the lockdown psychiatric ER for 10 hours because there's no beds. There's no beds to be had. And my beautiful middle-class white daughter, whose parents are in the biz, got a bed. And we were lucky. And in the back of my mind, I'm thinking, we're really privileged. And as sick as Linea was, she was also telling me the same thing. She said, please take me home. Let that homeless man who's on that gurney have my bed because you guys can take care of me. And that started our journey from not only really understanding how this impacts families, but also about the importance of when you have privilege, you have responsibility, and you speak out. I didn't speak out on my own. It was Linea pushing. So while she was in the hospital, she's been a journalist. She has journaled forever. She's also known a lot about disability. She called me one time at work and she said, "Mom, the guinea pig has Tourette's." I said, "Is he using the F word? Is he flipping? What's he doing?" And we found out, in fact, it was ear mites, so it wasn't Tourette's. But I knew all these things, but I did not believe that my daughter would end up with a diagnosis of bipolar illness. I really didn't believe it. It was a long process. But while we were there and she's writing, this journal, written in real time, became her way of hanging on, I think, to reality and a place for her to pour out her thoughts. And you're going to get to hear from her. I'm the research to practice person, and thank you, daughter, for helping me really get to the nuts and bolts of this. She's the person who's really living it. But I said to her, you know, maybe we should write a book. And she said we should. And she let me read her journal. And for the first time ever, I really, really understood what I'd been teaching about. And I'll tell you, I really, really got why my brother died of suicide. I was able to forgive. I was able to say, you know, this is an illness and we got to get it out of the corners of this room and we got to talk about it. And so she decided, yes, let's put this story out there. And I wrote my part of the book. She had less editing to do because hers was real time. I had a lot more editing to do while my editor said, dig deeper, and I'm crying over my keys. But it was so healing to put this out there. And we came out with the book, Perfect Chaos. And it was sold 2 days after she got her degree in creative writing. So when people say, what do you do with a degree in creative writing? She says, sell a book to a major publisher. Why, what do you do? So one last comment. What have I learned from this journey? So much. But what I would like to give you and leave you with is that I've always believed for people with disabilities, we have to teach self-determination. We have to teach advocacy. And I'm really big on social justice. I'm at a Jesuit university. But what I've learned from Linea and what I've learned from my journey is that self-advocacy and empowerment to speak out and finding a bigger community is essential to the recovery. Even if it's just talking to your psychiatrist and saying, I don't like these meds, but I've watched Linea find her voice, find her community, step out into the world, and I've watched her heal because of that, because of her good psychiatrist, her good psychologist, but also her embracing that this is a civil rights issue, and it shouldn't be hidden, and we should not be ashamed of this. So you're going to hear from the star in my life anyway. Thank you.
Thank you for having us. I feel so honored to be on this panel where we have all the important topics that I always try to explain already talked about. So this is so nice. It's nice to hear it from the media, from the research side, everything that I'm really passionate about, we get to talk about tonight. So that's wonderful. And thank you, Mom, for the great introduction. I am a person who lives with bipolar illness, and it was something I grew up knowing about disabilities. I did grow up with Herman having Tourette's and actually ear mites. But I found that the stigma, it's not just in the community, it's in ourselves as well. Because when I was first diagnosed, I grew up thinking that disabilities are normal, that a spinal cord injury doesn't mean the end of the world. It's these people are living amazing lives, that a disability is not something to be held back by. But when I was diagnosed with bipolar, I thought, not me. I don't have a mental illness. I'm not crazy. And just realizing that even in myself, I was stigmatizing myself and separating the mental illness from even other disabilities. And so it's been a really interesting process to watch myself move through that acceptance of myself, of my illness. And I think acceptance is a huge part in healing and being able to finally be stable. when I was on a suicide watch, I never ever dreamed of where I would be today. I never dreamed that I would be able to travel the country, sharing my story, traveling every month or twice a month, talking with people like Glenn Close about stigma, sharing a panel with Patrick Kennedy about advocacy, sitting at a table with Rosalind Carter talking about what it really is like to have depression. I never thought that I would have this opportunity. And I share these things because there's this amazing woman, Kay Redfield Jameson, who, when I first was diagnosed, she's one of the top researchers in bipolar disorder, and she also lives with it. And when I was first diagnosed, I thought that it was the end of the world, this diagnosis. And then I read her book, and I realized she could do everything she wanted to with her life. She was able to get her doctorate. She was able to become a leading researcher. And so I like to share with people that I am able to do everything I want to do. And I also like to share, I think it's important to talk about the fact that it's not like I went through these horrible things and now I'm better. It's not how it works. Mental illness is a lifelong illness. It's something that we have to learn to live with, to deal with throughout our lives. And so I also like to share that last summer I was given the amazing privilege to speak in front of the National Alliance Mental Illness Convention in front of about 7,000 people and share my story and talk about hope. And I was in one of the worst depressions I had ever had, and I was supposed to get up and talk about hope. And somehow I got through it. I had spoken enough that I was able to just talk about it and be honest with people, but a week later I was hospitalized. And I have to share this because in many ways for me, there's hope in that as well. Because I was hospitalized, but it was so different the third time I was hospitalized than the first two when I was first being diagnosed. This time I went in as an educated patient. I went in knowing what kind of treatment works for me. I went in knowing what to ask for, what to work on. I went in with having signed an advance directive with my mom. She could talk to my insurance company, and I was in charge as a patient, and that was really different. And in my mind, gave me so much hope for my future that if this comes back, I can deal with it, that I have the power to make my life better and to work with my illness, that it doesn't hold me back. After that, I continued to live my life. I was able to go to India and work with a community mental health team and see what they're doing internationally for mental health. I was able to win what I think is such a perfectly titled award, the Life Unlimited Award. And I think that that really speaks to something I'm passionate about, is that you have a life, you can have a life unlimited by your illness. You can live a life that you want to. And so it may take long, it may take longer. It took me, I thought it was horrible. It took me 6 years to graduate from college, but you know, taking a smaller class load was important. It may take huge support network, and it may take mentors like the ones I've met here and the amazing mentors I've had in my life. But after doing this, I've seen the hardships, but I've also seen the hope that's out there. And the hope for me is in pretty much 4 things. The hope is listening to Dr. Gupta talk about how he is actually making a difference in the media, that the media, someone in the media cares and is thinking about this in the right way. Hope is listening to the research and realizing that it's not a personality flaw. It's actually a brain disorder. It's not something I'm choosing to do. It's not something that is wrong with me because I'm choosing to do this. It's something that's actually in my brain. Hope is all of you caring and listening to us today, coming to this and having this be an important cause that you're willing to talk about and listen. And finally, hope for me is that I can continue my life, that I'm also, while I'm here visiting Emory and thinking about applying to grad school and thinking about the next steps in my life, whether I want to do law school or med school, and you know, that I can go anywhere that I want with this. So thank you for having us, and this has been an amazing panel to be on. I really appreciate Skyland Trail, the work that you're doing. Thank you.
You are a pretty amazing speaker. I wish my daughters were here just to be able to see you. You're so poised and so young still. What was it like, Mom? I know you guys have spoken together. What's it like when you see her up there talking and the way she is so poised but yet so candid?
It's been, well, she's a musician, and the first time I watched her walk up on a stage and perform, I was blown away because she's such a humble and kind and wonderful person, but she's so articulate. And it's, yeah, it's amazing. So when she tells me, Mom, hold the microphone like it's an ice cream cone. It's like, okay, I got it. But I think more it's her honesty, and I've said that between the two of us. I think it's our honesty as a family that has made this better, that we're honest about it. And it's her honesty, and her honesty, I think you all felt it. This is the real thing.
Yeah. You know, I think I asked this question in part as a parent, and you talked about this in your remarks. But what does a parent notice? What were some of the first things you noticed? I mean, how long between the time you noticed things and the time that you actually realized that something needed to be done?
I think that's the hardest question to ask yourself, and that we get from people is, how did you know it wasn't just teenage angst versus an illness, and as I wrote in the book, an illness that would almost take her away from us? How did I know the difference? And I certainly had more skills than a lot of people have, and I didn't know. She had depressions and anxieties in high school, but she was a super overachiever. So she's going all the time and then she crashes. So is that a mental illness, or is that an overachiever in high school? But I think we kept the communication open, we kept talking about it, and she kept saying, in fact, she came home at Christmas break right before she went back to school, and she said, something is coming and it will kill me by the end of the year. So she was very, very articulate about this. And when she became ill, and then I'll quit, but the hardest thing was when her psychiatrist said to us, we have to wait and see. You know, and I have autoimmune diseases in my family. My mother and my sister both, and I remember that initial wait and see as the symptoms unfold, and having partners to help us do that was so helpful. But it's a hard place to be, that wait and see, and how do you know, and you don't want to overreact, but you don't want to underreact. You don't want to not say anything, but you don't want to drive them crazy. So I don't know the perfect answer, but I think openness and knowing the symptoms, knowing what to look for.
Your brother had a completed suicide as well.
Yes.
Did that, I mean, when this is happening now with your daughter, I mean, how much did that enter into your thinking?
I actually wrote in the book that, you know, I was a mom that, by God, I was not going to lose a kid to suicide. I mean, I think I was over careful about the emotional lives of my daughters. Because of that, in the back of my mind, it was always, I've got to make sure that they're healthy. And so when she became ill, I think the hardest call I had made was to my parents to say, Linea's in the hospital on a suicide watch. And for a while I hesitated not even to tell them, because I thought because we didn't talk about my brother's suicide. My dad did not talk about it. And it came out of the closet, and I was like, this is an illness. I mean, it's a symptom, an end symptom of an illness, and we need to talk about it. So it very much played into this, the reaction.
And I'm gonna open it up here, but let me ask you as well, sort of the same question, but from your vantage point now. You're this overachieving young person, as your mom has described you. How hard was it for you to talk to your mom about this, or your dad?
Well, it was more hard to talk to my mom about it, which is interesting because my mom and I have always been very, very close, and I could talk to her about anything. Boys, if there was a friend who was cutting, I could talk to her about it. But the suicide piece, I feel like actually that's one of the reasons I am alive today, is because that was at the back of my mind, is my family has lost this already, and I know how much it tears a family apart. I know I love my mom, but she was a little overprotective, and it got very difficult. And I feel like you know, when she would call too many times, and but I feel like it was at the back of my mind as something that I wanted to be healthy for her as well, because I knew what it was like for a family to lose a child.
Dr. Kotwicki, when you hear this sort of story and you know, you hear that, look, this is a lifelong illness, and you can have periods where you're doing pretty well, but you don't know for sure. Can you talk a little bit about the course, the natural history, if you will, of bipolar disease?
Sure. I think all mental illnesses have sort of waxing and waning periods of time where people do well, and then there might be a trigger, loss of a relationship, a disappointment of you know, great magnitude that kind of precipitates another episode. And I think as Linea has been able to do, she now knows the red flags, she knows the warning signs, so it doesn't get to the point where she's isolating in bed and not going to school and starting to have thoughts that are uncontrollable. She can do something about her situation much sooner, which is really the idea that we would like for everybody to be able to, who has this lifelong medical problem, to know when to start the preventive services so that it doesn't spiral out of control and produce disability.
I asked Cinda this, but what is the guidance or advice for parents out there? I mean, what do you tell parents if they come to you and say they have concerns?
Love your kids. And I don't mean to be flip about that, but the things that parents can do to help kids who are in the middle of any kind of crisis like this are to do all the things that human beings need, to support them, to not judge them, to make sure that all of the resources that are possibly available are obtained, and to be fully engaged and present. And I think one of the most difficult things for families to do, from my perspective and my editorial, is to stop sort of thinking about how having an ill person in one's life affects oneself, and how it can be very useful to focus on other people and other things, even in the middle of feeling out of control on your own.
Are we doing better, Dr. Crosby, in terms of connecting at-risk people, especially young people, with the services they need?
We're doing better. I mean, there's definitely a long ways to go, but I think we are doing better in terms of certain kinds of programs. You know, one of the big strategies that is being used in many states and in many communities are what they call gatekeeper programs, in which part of what they're doing is they're training people in the community. That might be a teacher, it might be the letter carrier, it might be clergy, it might be someone else, to recognize those people you come in contact with who might be in trouble. And if you recognize that they're in trouble, you know, he's not doing his homework like he used to, or he's hanging out with a different kind of crowd, or, you know, isn't coming to answer the door, you know, to pick up the mail the way he used to, then part of what you do, that's the recognition and referral, that you're trying to get that person to, or you may make the call, you know, to try to get that person into the appropriate care. And I think it's again, one of the great things that there's a national crisis hotline, which is 1-800-273-TALK, in which not only can a person call in because they might be concerned about themselves. I'm having some problems, but you can also call in on behalf of a loved one or a friend, that you can call in and find out about services. And what that national line does is connect you to the local certified crisis center. That if you're calling from Atlanta, they'll connect you back to a crisis center in Atlanta, that you can find out about the resources in your community. So we're doing better. We definitely have a ways to go, but there are definitely things that are happening in positive things.
I want to start taking some questions from the audience. I think we have a couple questions over here. If you wouldn't mind just stating your name, if you're with a particular organization, and what your question is. Do you have a question? Or does anybody have a question? Please. Yeah.
Good evening. I'm Charles Winkler, and if indulgence, I'd like to just briefly speak about some feelings I have, and then that may lead to some questions. I'm 62 years old, and until my son had a psychotic break a year and a half ago, I was completely ignorant of what is mental illness. So I've reflected on that, and I've come to believe that I'm not alone in that in our society. I think we have a great ignorance of what is mental illness and what it means to us. And I think it's very detrimental to our society overall. As an example, there is mental illness in my family, never spoken of when I was growing up in Central Texas. As later in my life as an adult and a mature adult, only referred to in oblique terms, never anything direct, so there's no communication or way for me to connect with that. And the feeling I have is, honestly, is one of anger. Not a vociferous anger, but kind of a simmering anger as I've reflected on this. Why do I not know about a large segment of our population and what they're experiencing? I think the course of human history, we should have learned that hiding things, making secrets of things, suppressing information, it does not benefit us as human beings. It's exactly the opposite. And so that's one of my thoughts I wanted to share with you and a feeling. For me, it's too late. I mean, I've lived a lot of my life not knowing about many of the people in society. If someone had asked me before my son experienced a psychotic break, well, how many people in the United States suffer from severe mental illness? I would have said, I think a very, very tiny number. And if someone said, what kind of treatment do you think those people are getting? I said, probably, adequate treatment. Both of those, of course, completely wrong. And I do not think I'm alone in that. So my thoughts are, why should this be this way? Can't we start with public education when children are young in school, learning about the human body in a more realistic way? Mind and mental health, mental illness is part of that. Our health courses in school, can it not be just simply brought out and discussed as well as other illnesses? Why would it have to be any different? I think that the younger folks, my 3 sons, this beautiful young lady up here, are more accepting than my kind of rigid older generation of these differences, and I think it shouldn't be overwhelming. I think we could make a big change, but I believe it needs to go beyond this very highly educated audience here. I appreciate seeing, and to the mass public in a way that starts with elementary education or some other means. Thank you.
Thank you very much. I mean, he makes the point, Ray. I think that, and we live in a community here where we have Skyland Trail. But where is someone like this gentleman to get information right now? For the first time in his life, 1.5 years ago, because of what happens to his son, this now becomes the most important thing in his life, sounds like. What does he do?
Well, I think first to respond to his really excellent point, there's this fear that by talking about something makes it more likely to happen. So if I talk about suicide, maybe I'll suggest to somebody for the first time who wasn't formally thinking about suicide to commit suicide. And that's just simply not the case. Talking about things actually makes them, we think from a psychotherapeutic point of view, less important rather than more important. So any way to begin a dialogue, I would caution people from only using the internet for resources on mental illnesses, because there are a lot of things that sound sexy and sound interesting that are not evidence-based or factual. And so I think really identifying somebody who's a trusted ally, whether it's a primary care doctor who, for better or for worse, had to take at least 4 weeks of psychiatry in medical school, that's a great point to begin a discussion, and then negotiate whatever the surreptitious route is in a community to get to somebody who can really truly help. I think it's impossible to come up with a stock answer for that question because unfortunately the shambles of the mental health system that we have in our country, and particularly rural areas, make it impossible for there to be a direct conduit to get help for families who need it.
Please, if you wouldn't mind just telling us your name, who you are.
Hi, good evening. My name is Shauna Magadzi. I'm a recent Emory graduate, and I'll be applying to medical school next year. And I'm actually really interested in psychiatry, and that's part of the reason why I came here tonight. One question I have for the panel, really, is I remember Dr. Kotwicki, he mentioned about how the stigma is actually, it's quite ironically, very pervasive in the medical profession. And I feel like a lot of these issues really could be attacked at a more sooner state. So what do you propose at the graduate medical education level? What would you say to deans of med schools across the country to, I guess, tailor curriculum that would allow med students to be more open to psychiatry, open to mental health professions, and, you know, having a kind of mindset where when you are in the ER, you know, you're looking at a very holistic way of treating the disease rather than just putting it in a box and sending it to a psychiatrist. So I guess at that level, are there any suggestions?
Yeah.
Okay. So I've thought about this a lot, and I think that the sort of crux of my idea is in something that you said, which is that we need to select medical students who will treat people rather than treat diseases. And by definition, if we can identify who that person is applying to medical school, we will undo, I think, within the medical community, the stigma associated with mental health. I think admissions committees have a really important and very difficult time being able to say, I value research, I value MCAT scores, I value your transcripts, but at the same time, who you are as an individual and how much investment you have in the person identified as your patient sitting in front of you, telling you these personal things about themselves and their life narrative. That's the way that we can train good doctors, is to figure out how to do that.
When you hear about these disparities, Dr. Crosby, I wonder if you can give us some idea from your perspective at the CDC, the Centers for Disease Control and Prevention. You work in a very specific area. How is mental health research funded within a big governmental organization like yours?
Well, it's definitely not funded at the level for which, if you look at the burden of disease in our population, it is definitely underfunded. And I think as was mentioned in terms of what Dr. Satcher was doing as the Surgeon General in talking about mental illness as being a brain disease and talking about that as one of the things that he was going to champion as the Surgeon General. Here is a big missed opportunity for those of us in the health arena for trying to deal with it, and again, trying to look across society. So it's definitely underfunded. We do have some systems that try to look at mental illness, the burden of mental illness across the society, some of the interaction between mental illness and chronic disease, for example, diabetes and clinical depression, or heart disease and clinical depression. We also try to work with some of our other sister agencies, if you will, within the federal government, for instance, SAMHSA, Substance Abuse and Mental Health Services Administration, as well as National Institute of Mental Health, to try to look at the types of basic science research, the type of programs that are being implemented, how can we evaluate them, and then also how can we monitor what's going on in regards to what kind of manifestations there are in the society.
Perfect. Please, I can't see over there. Is there a question over here? Okay, I'm sorry, right here. If you wouldn't mind just telling us your name and who you are.
Yes, my name is Tom McMahon, and I'm proud to say that I'm an alumni of this fine institution. And there's been a lot of very good topics brought up here. And one of the things that really bothers me about our society, I know more about how to take zinc when I have a cold, or how to take this medication when I have this symptom for something. And there's a recent commercial on that talks about, oh, take this, I don't think I should say the name, but take this medication if your depression medication isn't helping you. And it's done in a commercial, kind of like not a serious way. It doesn't really talk about, oh, if your medication isn't helping you and you're feeling depressed and you're feeling that hopelessness and going down, take this medication. It doesn't talk about how serious that is, and instead it puts it in a comic term. And what I see in the United States is we just don't have the funding to talk about and educate other people. I was fortunate enough to go to Skyland and get educated. I mean, I lived it. I knew what depression was because I went down there, and it's a horrible thing, but no one really says that or portrays that in the media. And I'm not criticizing the media. It's all sources of inputs that we receive. It just doesn't talk about that despair, that hopelessness that we who have the illness live every day. And if we could do that, that would enable the families to understand how difficult it is to live with this disease. Because many families just don't understand that. And I wish there was some way we could get governmental or U.S. federal funding and state funding to educate people. When I was going through school in biology, you never heard about, the biology of the mind and that it causes or you can have mental illnesses from that. But my only point is, I wish there was more money made available to address what we who suffer from mental illness experience so more can understand that. Thank you.
Getting to the point of education seems like it's a very laudable goal, but you described the mental health system as in shambles. It's underfunded, it's fragmented, especially in rural areas. Can you put that in some context? And what does that mean? If you compare it to somatic illnesses, or what is life like for someone who doesn't have, again, a Skyland Trail in their backyard?
Well, unfortunately, the de facto mental health system has become the criminal justice system. So as Mrs. Carter has mentioned very accurately, the largest treatment facility in the country right now for people with mental illness is the LA County Jail. And what shambles means, I think, is that the social prioritization of being able to help provide not only treatment and medications and psychotherapy, but housing and support for families and substance abuse treatment and everything else that can allow somebody to be empowered to recover from a mental illness. None of those things exist in some places, and where they do exist, not everybody can access them, which means that the funding that provides containment and services for them shifts to penal justice or criminal justice system. Georgia, fortunately, has done pretty well in training police officers through crisis intervention team training, how to better identify whether or not somebody's misbehaving because they have a mental illness or if they're acting maliciously, so that they can be diverted away from jail or prisons into treatment. But eventually, as Cinda and Linea have suggested and their own experience, there are a certain limited number of beds. And the number of people who could benefit from evidence-based, respectful, timely mental health services far outpaces the number of beds available.
You said you and your husband are in the biz, and that's in part how you were able to get the treatment that Linea needed. What would you have done if you didn't have that option?
And again, we get the questions like, well, this is great, but what about when you don't have all the resources we have? And I think that's one thing that everyone in this room can do, and it's one thing I tell my grad students is I think everyone that can should know what resources are out there, and when someone brings up this issue, you can connect them to the National Alliance on Mental Illness Family to Family. You can connect them to depression, bipolar support. You can give them the crisis phone number. I think that if I were that single mom working 45 hours a week and had this daughter going in crisis, I would hope I had a community to help me. And so I think we have a responsibility to be that community and to speak up. I don't know where we would be. I mean, when she first was in the hospital and locked down in Harborview, She was 19 years old. She was this beautiful girl, and she was one of the few females in there. She was one of the few people who had a home, and she was one of the few people under 45 years of age. I was terrified. I was just like, I can't leave my kid here with those people. Within a few days, I realized those people are this close to being this person. I mean, we're all in this together, so I didn't really answer your question, but I think we have to speak up for those who can't speak up. I really do, and I think we have to make phone calls and talk to our legislators and know our own resources and fight the fight, you know?
Linea, as you go around the country talking about this and big conventions and I'm sure a lot of personal discussions, are you more optimistic, more encouraged?
I am. I'm encouraged because I feel like people my age are starting to talk about it more. I see this big movement with anti-bullying and gay rights becoming big in high school, and I feel like the mental illness movement can come next. I feel like it's paving the way for it. We're starting to talk about depression in both of those movements, and I feel like that gives me a lot of hope as I've gone around the country and heard about these being implemented in high schools. But we hear so many hard stories all the time, every day. Anytime I tell anyone, it affects everyone, and it's heartbreaking to hear all the people that aren't getting resources and all the people who just have nowhere to turn that we talked about. And I think it is a responsibility of, if you have the privilege to speak about it and try to help those people. If you've been through it, it's time to speak out, because we can't keep it in the closet forever. It's going to keep just getting worse.
What do you think the impact of social media and the ability to share things so quickly, so broadly has on this issue? Do you think it helps, hurts?
I think it's actually been helping a lot. I think it's been really interesting for me to see that for a lot of people, they can now, when I first was dealing with it, I journaled because I had no one I could talk to, but a lot of people now can anonymously sign into sites like NAMI has this young adult social media site called Strength of Us, and they can tweet about their feelings and have others tweet back, I'm feeling the same way and this is what I'm dealing with. And so there's now this online communities where people can start talking about their feelings without having to do the very scary face-to-face right away. So I think that's very positive. Along with there's more bullying online, but also I feel like there is a positive role being played.
Dr. Crosby, you didn't talk about this specifically in your remarks, but leaving aside the dire statistics about suicide affecting younger people the way that you showed, what about awareness like Linea is talking about? Is there greater awareness among a younger generation versus, for example, the gentleman who was 62 years old was talking about? Do you look at that? Do you notice it?
I think that young people are more willing to talk about it. You know, there are other organizations, for instance, Linea mentioned a couple of things like Active Minds. This is a group that was started on a college campus by a young lady who had lost her brother to suicide, and mental illness was a component of that. And so those kind of organizations are being started by students all over, you know, to try to talk about it. Let's share, you know, our stories. And one of the things that we've been looking at in terms of protective factors is that connectedness, that social support, that if you've got somebody that you can talk to, especially somebody positive, you know, whether that's in your family, whether that's somebody, an adult in your school, you know, whether that's, you know, in an institution, faith-based institution, other kind of organization, that those tend to be very helpful in regards to helping someone get over some, you know, rough spots that they might encounter.
Please, if you wouldn't mind telling us your name and who you are.
And panel, I just want to thank you and Skyland Trail for taking this time tonight. This has been something I've waited for some period of time. Dr. Gupta, I want to thank you for being a voice in the media for us. Dr. Kotwicki, as a school teacher, I believe firmly in research-based and your body-mind connection. I am a great fan of yours. Dr. Crosby, children sit in my classroom with psychiatric problems and they're not getting the help they need. And I know that, and their parents are frustrated and nobody knows where to turn. Linea, I wish you had been with me Sunday when my young adult was crying and saying, this is not where I want to be. This is not how I want to be. Everybody my age, my friends are doctors, they're lawyers, they're having children, and this is where I am. Any little thing she says is a huge celebration, like she made the comment, I'm beginning to own my psychosis. I could have done cartwheels, but I just pretended that was just natural conversation. So I just want to thank each of you for what you're doing, but my specific question, I mean, everything, your social justice, I agree with that completely. If you don't have money, you're not getting treatment. I've seen it and I know it. And that breaks my heart. But the specific question I have is when you're a family dealing with a young adult, it is extremely difficult to get them into treatment because they have rights, and you as siblings, whomever, you cannot get them treatment. And that is a very difficult thing. Thank goodness I have 6 children, so my child has 5 siblings who are active in internet research. So they find out how to get these things done, and they have no problems calling from California to Georgia and speaking to judges and saying, you must, what can we do? And getting answers. So, but that's a huge concern that we have as we meet other people is how do you get a young adult who is past 18 into treatment? So if you have any insight on that, I'd love to share it with people.
Well, let me have both of you sort of take a crack at it. Maybe Dr. Kotwicki, you want to go first?
Yeah, I think this is a real challenge because obviously there's an autonomy paternalism kind of balance that comes into play. And I think that Linea and Cinda made an allusion to something that we haven't talked about too much, but I think is really important, especially for young adults who are trying to exert independence and individuate from their families and everything else, which is this idea of a psychiatric advance directive. And what it allows a young adult to do is to say, if I'm ill and I'm symptomatic and I have these things that are happening to me, in my current way of seeing the world, in my current state of mind, these are the things that I would like to have happen. And then it can become a legal document in states where this is a valid thing to do, and people then follow the directive as a blueprint for respectful care. In Georgia, and all the different states have different mental health policy laws. You can involuntarily commit somebody for an assessment for a certain period of time, but the assessment clause does not include treatment. So you can, observe the person and do some lab tests, but you can't medicate people against their will. And I think that those laws vary between states depending upon the political milieu in whatever state. So I think that engagement is really the key to helping people recover from mental illnesses. We have treatments that work, and we know that there are good things available to folks if we can get people there to participate. And I think the Advance Directive is one way that that makes it easier. I'd love to hear you present.
What I was going to say as well is, for me, the Advance Directive was really helpful because it allowed me to be in charge of what I wanted. But it also forced me to think about what I want in these situations because it asks you questions about, do you want electroconvulsive therapy? Do you want to be medicated? It asks you all of those questions. So I had to think about it ahead of time when I was in a stable place. Now, not everyone, of course, sometimes there's a psychotic break. That's the first instance. So that's a lot harder. I'm not sure. That's always the hardest question I think that we get is, what do we do? Our child has had a psychotic break and they can't give consent. That's one we haven't found an answer for yet. But that advanced psychiatric directive is very helpful, I think.
We got a few minutes left, so I want to get as many questions as possible. If you wouldn't mind, just tell them your name and who you are.
My name is John. I am the father of a 25-year-old son who has been suffering from schizophrenia since he was 12. And The good news is he's a recent graduate of the Skyland Trail program and is in the best place in every way that he's been since he was 12 years old. That's the good news. Of course, he continues to struggle, medication issues, social issues, anxiety issues, and will, we assume, never be well. He'll deal with this forever. Linea, you gave a wonderful, encouraging testimony of hope about reaching for all you can in spite of your illness, doing everything you can with your life. My struggle as a father with my son is where I draw the line between encouraging his hopes and dreams, but at the same time helping him face the reality of his illness and the limitations that it does impose on him, because it does. Thank you.
My dad and I have that conversation all the time. He is not, I don't know if he's a fan of me thinking about law school and med school. He's a little nervous about the anxiety that it'll induce and where I might lead into with that. And I think that those conversations we have are always so important in me strengthening if this is the right decision for me, because we have a great relationship, and so I really listen to what he says and value what he says, and though he might not stop me from doing what I want to do, but it does make me be like, okay, is this actually the right path for me? I shouldn't go to law school and med school at the same time. So I think that having those conversations are so important still, because it allows your son, it allows me to really think about my limitations of what works for me in my life right now and what could work for me in the future as I learn more about my illness.
Panel. My name is Christopher Carlton. I'm the director of Emory University's Clergy Care Program. I'm an ordained Methodist minister and a licensed professional counselor. My question to you is this. Dr. Crosby mentioned that spirituality is a preventative factor in preventing suicide, and we also know that it plays a role in recovery. The first question is, why do you think that is the case? And secondly, what can faith communities be doing to advance and to destigmatize mental illness and to advance access to treatment? Thank you.
I think in regards to exactly why spirituality is a protective factor, I don't think we know all of the answers. We know some of the things that probably contribute to it. I think that there's definitely the aspect of someone is connected to a common belief community in which you've got people that care for you, and they'll know, something's not exactly right, and they'll be ones who can provide for you and help you through some difficult times. I think definitely we've got to consider having that belief in a higher power is probably also protective. I don't know that they've been able to actually tease out exactly what it is about spirituality that makes a difference. Your second question had to do with how can we make clergy or faith communities more knowledgeable, and there are definitely some that have actually come up with, I'll call it a policy for lack of a better word. I know the Evangelical Lutheran organization, for example, has come up with a statement about this is how we're going to deal with those that are suicidal or have need of services within our faith community. So I think that part of it is education, awareness, making sure that the clergy are also as the leaders within those communities, making sure that they don't have those same kind of discrimination and stigma beliefs themselves, and making sure that they're open to trying to listen to it. I'm sure that many of you who have been involved in faith communities, and this goes into the larger society too, have heard, things about, if you just prayed more, you'd be okay, or, if you just pull yourself up by your bootstraps, you'd be all right. And we realize, no, that's not the whole situation, and definitely not the solution. So I think we do have to educate those within faith communities about, what is the reality of these illnesses, just like they know a little bit more about diabetes and high blood pressure and some of those other chronic diseases, and understand that, yeah, you need to go and see a physician, but we're also here to support you. Can we get those same kind of attitudes regarding mental illness?
please.
My name is Sarah Little, and I am actually an alumni as well as Tom. And this actually is a question for Linea. It's just really quick about, like you said that you understand that it's not going to be an immediate thing. It's not just going to be a flip of a switch for you to know and understand, like, okay, let me just finish this. Some of the ways that you come to accept and living with bipolar and not using it as a crutch or using it as blame to maybe some of the things that happen. I was just curious to know what you did.
So I think for me, acceptance has really been a roller coaster. I will accept that I have the illness, but I won't accept that I need to get accommodations. So that it was another level that I needed to reach. I would accept, okay, well, I have to take medication, but I don't have to slow down my life in any way. And so I would deal with kind of each phase of that. And I think one of the biggest times I've had recently of acceptance is I thought I had accepted my illness, but when I was hospitalized again last summer, I just got that anger again of why me? Why does this have to keep happening to me? And did I fail somehow? I thought that I figured this out. And so again, I had to really talk through it with myself and journal and talk to my counselor about that level of acceptance of it really being a lifelong illness, and that and of not, you said not using it as a crutch, of also making sure that it's not something that I'm holding myself back because, like, I have this bipolar illness and I can't do it, of realizing, okay, I can do it, I just have to do it slowly. I have to make the right decisions based on that. So, thank you.
I have so many questions, and yet we're running out of time. What did you tell your dad, by the way? Because I know you're going to go meet with people at the law school and medical school tomorrow.
Well, I haven't told him.
You haven't told your dad?
No, I've told him. It's an ongoing discussion.
Sounds familiar. It's
an ongoing talk.
I know we have a lot of questions left, and we are getting short on time. So maybe we'll take one more question. Maybe people can stick around on the panel afterwards for some more. We have about 5 minutes. Okay, please, yeah.
I just want to say my name is Amy Zolkowski, and I do have bipolar. And basically, a long time ago, my mom, she has schizophrenia. My dad didn't know where to go. So she had religious hallucinations. So he went to our local church, our pastor, and he said, oh no, she's just getting religious. You know, she's found religion. So he knew better than that. So I think community education is a very good idea. So he turned to our Catholic priest. So he went there and he says, no, something's definitely wrong with her. So, and he says, this is what you need to do. So he told her where to go, and she went to Charter Winds and got some help. So after that, she eventually took her medicine and got all better. So she talked her psychiatrist out of taking her medicine and got sick again. And I'm so glad that he actually got help for her, because when I got sick, he knew what was wrong with me and what the symptoms to look for, because without that, he wouldn't know. So, but to actually get help from me, I got help when I was a child, got sick when I was a child. I was in and out of the hospitals, but for him to actually get help from me, he had to sue the school system. Because they didn't have the money, because the hospitals had actually used up all my insurance, and I was going in and out of the state hospitals. So they sued the state schools, sorry, I'm nervous, but they sued the school systems, and he was actually able to get me help. I spent 1.5 years in a treatment center for children, and I was able to graduate high school. And then I've actually held jobs, you know, since then, but I think, my point is, I think community education is very good. And I just want to say that my husband has been here also. He's been treated by Skyland Trail, and he's able to hold a full-time job, and different people with mental illnesses can do different things, function at different levels. So I just want to say thank you for all you've done and what you continue to do.
That has to be very gratifying, Beth, to hear. I mean, so many of these stories. I mean, it's get a little choked up. Please.
And I'll be quick. My name is Margaret Sisson, and thank you for this panel. We don't see this often, and as a mom of a young adult, Cinda, thank you for being honest, and as a parent, I understand your struggles. This facility was life-changing for my family. As a parent and an educator, I'm passionate about getting in our schools and educating our administration and our teachers. It doesn't happen. There are a few that know, but the majority don't understand mental illness, and children are passed on, and it's a bad system. That's my question, and that's what we can do about it, and what we can do it as a community. I would love to hear more about that, because I think we as individuals and we as a group can make a difference in that. And we have facilities like Skyland that will help. We need to be really proactive in helping our children and young adults. I think we're seeing our young adults, and Lydia, what an inspiration you are, because our young adults are, it's tragic what's happening. And so I'd love to see more through our school system. Our colleges don't understand, colleges aren't educated about the mental illness that is happening. It's such a stigma that no one talks about it. So thank you very much.
Thank you. Dr. Crosby, let me just ask as a final, when you hear that, I mean, there's so many different spheres of our society, the spiritual sphere, the scholastic sphere, obviously the medical sphere. Should there be at the grade school level more education? I mean, is that where you think this needs to start?
I think that's definitely one of the places. I want to take issue with the young man that stood up and said he was too old. And while we do have that saying, you can't teach an old dog new tricks, you can. And so I think it's not too late to teach our whole society about more tolerance, about knowing what some of the resources are, and about meeting people. And while we said, many people have mental illness in the family, I think maybe like his example, they didn't talk about it. But knowing someone that had it oftentimes opens up people to be able to, yeah, I can address that. Yeah, I remember I had an uncle, I had a grandmother, I had somebody else in my family that had it. And understanding, too, that it's not voodoo, it's not something strange, it's not something we can't do anything about. But yeah, there are treatments, accepted treatments, evidence-based treatments for which we can do something about it. So I think there's definitely awareness, there's education, exposure to people that have the disease and can talk about it and say, look, this is where I've come from. I've read Unquiet Mind by K. Redfield Tomason, and I know that there are folks that have gone through this, they are dealing with it and are able to achieve. So I think that those are some things that are helpful.
Thank you, all of you. And let me just say that I'm encouraged, inspired, despite some of the tough topics tonight. I'm going to walk away a little bit more optimistic about this, and I vow to all of you and to all of you that I'll continue to do my part in the media to beat the drum, to make sure people are educated. How about a warm round of applause for our panel?
How about a big round of applause for Sanjay? Thank you, Sanjay. Wow, I have worked in the field of mental health for close to 25 years, but conversations like this always give me something to think about. I made a few notes. Ray, we heard from you, and I've heard this many times working with Ray day to day, how important words are in our communication about mental health and about the inextricable link between mental health and physical health. Alex, we heard from you about suicide prevalence rates and the fact that suicide is a very significant public health concern, and that suicide prevention strategies, that there are many that we should consider as we address this growing problem. And people, and Cinda and Linea, we heard from you. It's so wonderful to hear from you and people like you who courageously share their stories of hope and recovery. You renew my appreciation for those who fight to overcome mental illness, and along with their friends, families, and professionals who support them in their recovery. They talked about their book, Perfect Chaos. We will have this for sale as you leave tonight over in the dining room, so please, as you walk back through the facility to get to the valet parking, stop in the dining room and pick up a book. I hope that we leave tonight with a greater understanding of the role we can all play in confronting stigma head-on and enlisting some of the strategies we heard about to support each other and to foster healthy communities. We know that 1 in 4 Americans live with mental illness, and the consequences of stigma, isolation, and lack of access to treatment can be profound. But we also learned, and we know from experience, that there is hope. I again want to express my appreciation to you, Sanjay, Ray, Alex, Cinda, and Linea, and my heartfelt thanks to Edwina and Tom and Rex and Duval for giving us this series. We are grateful for this enduring gift of in honor of a very special woman. And finally, I want to thank all of you out there. Sanjay, you're right. It's very gratifying to hear all of these stories, to see a lot of our alumni out there. I'm humbled by your stories. I'm humbled by your struggles, your dreams, your hopes for the future. I hope that all of you who spoke tonight and made comments and suggestions and asked questions, I hope all of you leave here with a greater sense of hope. Thank you all so much for being here. And we look forward to seeing you again next year at our Dorothy C. Fuqua Lecture series. Have a safe trip home.